Hello. Yes. Hello, dear friends. I'm Dr. Bansi Sabu. I'm Secretary and Head for Diabetes India. I'm thankful to Dr. Naresh, my close friend, that they have partnered with us for this joint webinar of primary care diabetes obesity from UK as and in Diabetes India. We are going to have our annual Congress of Diabetes India, which is World Congress of Diabetes India and obesity in month of Feb, which is from 13th to 15th of Feb at Hyderabad International Convention Center, where we will have Naresh and we will have PCDO symposia also. I'm very thankful that PCDO had given us permission to partner with him, and we will have more program in India because primary care is to be strengthened for obesity management. And as we know that in India we have 354 million people as far as data of 2021 ICMR in-depth data which we had shown of central obesity. Our obesity may be little different. We have more of visceral obesity. We have more of fat percentage in our body. Even BMI may not be the right or accurate way of diagnosing Indian people with obesity. So that's a real challenge. Sometimes people with BMI of 26 or 27, you may find their fat percentage may be more than 40 or 50%, and they are prone to develop all sort of metabolic complication, which one Caucasian may not have with the same BMI. So that's a challenge, and we have coined the word thin fat Indian, which is very popular in particularly Asian conditions. Today we have three experts. Before I introduce them, I will request Dr. Naresh to introduce PCDO to Indian colleagues as well as also to introduce the faculty for today's program. He'll be also introducing overall the structure of program because he designed, and then later on we will have discussion after all three talk. There can be some questions and comments. Those who have joined another platform, they can write in a WhatsApp or the chat box or through RX event AV team. We will get their questions and we will discuss all those questions also. And plus, if any comment you have, we'll be very happy to have those comments also. Thank you. Now over to Naresh for your introduction about the society, and then introducing the speaker and topic.
Thanks, Banshi, and welcome all, and thanks for giving us the opportunity to be part of the webinar. I think it's the first webinar we are holding together, Banshi, between Diabetes India and PCDO UK. PCDO UK is the largest primary care diabetes and obesity society. It caters to all primary care, whether you're nurses, doctors, GPs, pharmacists. I think we have close to about 18,000 members, and we run 4 or 5 conferences during the year. And so one of the big things for us is, like Banshi talked about, the thin fat Indian. We are seeing a lot more South Asians in the UK, and all of us are getting more and more knowledgeable about how to manage this particular cohort of people. And our society, I hope we've decided that we'll collaborate more widely and hopefully to help us learn a bit more from you guys, and also share our expertise and our modules that we prepared with some of the expert panel that we have today. So I think we'll just introduce my colleague, who's a consultant pharmacist, Hannah Bieber, who's going to start the first session for us. And she's going to be looking at from prevention to personalization the next year of obesity and diabetes management. And then I'll follow in from that, and I'll introduce my colleague, who's also a consultant nurse, Jane Diggle. But we'll first start off with Hannah. Is that okay, Hannah? We'll let you get on.
Thanks, Manish.
Yep.
Perfect. So thank you very much for inviting me to speak at this webinar today. Today I'm going to be speaking, as Naresh has said, about from prevention to personalizations, what the next steps are going to be in obesity and diabetes management, and I've looked to embed some case studies to help us take that journey today. As Naresh said, I'm Hannah Bieber, I'm consultant pharmacist for diabetes, and I'm a clinical lead for obesity at West Yorkshire Health and Care Partnership in the UK. These are my disclosures. So really today I wanted to start with an intervention decay model. So this really shows us how we need to be bridging the gaps here in our type 2 diabetes care journeys. When we think about kind of the steps that we need to take in order to keep people safe and effectively managed, from knowing that somebody has diabetes to making somebody aware of their diagnosis, to making sure that they've got those eligible interventions, and to be making sure that they're optimized and that it's a plan that that person can execute. We really need to start filling these gaps down at the bottom there much more effectively. So we need to do better at raising awareness and helping people actually understand their condition, to help people access and uptake therapies as and when they're needed. We have a huge amount of unwanted variation in the UK, and I'm sure that's the same in India. And we need to come up with plans that actually work for people. People are juggling an excessive amount of things, from jobs to economic complications of their lives, to children, to all these different things are going on around the care that we provide. And sometimes we can become very siloed in our thinking about, starting the medicine that we want to start because it's the new shiny thing on the shelf. And I think we don't do enough thinking really about this bit around implementation and how we get a real robust impact for the things that we're investing in as a healthcare system. So we'll talk as well about an intervention decay model for obesity a little bit later on. But this just kind of highlights here around the sort of areas that we need to start thinking about, not just the therapies. So to start to kind of have a think about this, we've got here a patient, Mr. J. Mr. J is 58 years old. He's a truck driver. He's got a BMI of 33. He's uncontrolled with his HbA1c. He's got CKD stage 3A, and he's got a cardiovascular history there of an NSTEMI, and he's been stented. As far as the regime is concerned that he's on metformin with a basal glargine and prandial aspart, but this basal bolus with the metformin is not working for him. It's been inconsistent in use, and he forgets his midday doses regularly. He is on empagliflozin and he's on a high dose statin, and he has been given lifestyle advice, but he's got real fast food reliance because of the fact that he's out driving a lot of the time, and he skips insulin to avoid hypos as well because of his profession. So the clinical call out from this really is that Mr. J is the sinking patient. He is, despite insulin intensification, experiencing dropping through a gap quite spectacularly due to the complexity of his regime that doesn't work for his lifestyle, the fact that he fears hypoglycemia, and the fact that this lifestyle advice that we've given isn't actually compatible with his life. So what can we use to be this clinical bridge? And it's going back to basics. These are the things that we would do now, isn't it? We're starting to think about what's this person's risk factors, what's the clinical bridge that we can make that solves as many problems and treats as many things as we can with Mr. J. And so something like semaglutide, and looking at the SUSTAIN-6 trial outcome data there on the left, he has had established cardiovascular disease. He's got a prior NSTEMI, and he's at extreme risk for a recurrent event. The mechanism, the semaglutide would lower his triglycerides. We know he's got a very unhealthy diet, and it will reduce inflammation and improve that endothelial function. So, and also in addition to that, just practical things, replacing an inconsistent prandial insulin with a weekly semaglutide would help stabilize the profile of not taking the insulin when required, and could actually also, in addition, have an effect on reduction of his stroke risk, which would be in cooperation with the fact that he is just genuinely a high cardiovascular risk. And you can see here from the SUSTAIN-6, really good outcomes there with MACE. You'll have seen this data before, and really good outcomes there in reduction of non-fatal stroke, which drove a lot of those outcomes. But it's more than that, isn't it? We're trying to do as many things as possible. And one of the things that semaglutide has also been in the press about is around its kidney protection, particularly those with overt albuminuria. And the FLOW trial really did show some impressive outcomes around this. We know Mr. J has stage 3A CKD, he's got albuminuria, and he is a candidate for rapid progression because of his cardiovascular history and because he's already showing signs of chronic kidney disease. So starting something like semaglutide would actually really help. 24% reduction in kidney disease progression, 20% lower risk of all-cause mortality, and actually it might save 1.16 mils per minute per year of renal decline. And there's synergy here. He's already on empagliflozin, and so using those combined semaglutide with the empagliflozin would provide a dual pathway of nephron protection through both hemodynamic and anti-inflammatory mechanisms. But what might the future hold? So that's kind of what we would do now. We're starting to think about these cardiometabolic medicines in a more holistic way. But what might the future hold? We're going to have these medicines, but what might we do better? So I think that a big change going forward will be from trial and error really to this more algorithmic precision. And this is an example of that, is the Exeter predictive model. So the Exeter predictive model takes all of these demographics on the left here, looking at age, diabetes duration, HbA1c, BMI, EGFR, ALT, and cholesterol. And it looks to use an AI or algorithmic approach to understand what would be straight away, what would be the best option for this person to manage all of their risks in the most sensible way. So rather than having to do a stepwise approach, which sometimes can take years, decades even, for somebody to work through all the different permutations of drugs, this gets somebody flowing a lot more freely from, you know, what is actually going wrong here to what is the best solution, in a much more streamlined way. So really what we're looking at is predicting glycemic effectiveness and complication risk, and we're immediately starting to optimize HbA1c reduction and lower poor outcomes. In real time, hopefully we will see that this will also link in the future to things like CGM data and start to really drive and think more in that AI space about how we kind of start to piece also together some of the holistic information about people, their lifestyles, etc. AI would hopefully have flagged straight away that semaglutide and SGLT2 immediately post-metformin would have been good for Mr. J and avoiding years of insulin-induced weight gain and treatment failure. So thinking now about obesity, so similar sort of approach, thinking about where do people fall through the net, and the biological reality of weight regain is huge in this area. So key insights in this area are that our biology defends the highest weight without targeting neurohormonal drivers of this. Long-term maintenance is statistically very improbable. And this really is the foundation of what we need to be doing and recognizing in obesity care. So the obesity intervention decay loop thinks about what is that intervention. It's got to be more than calorie restriction. We've got to think about how we adapt our metabolic processes so that the set point can't fight back. And so then that person doesn't experience what can be quite traumatizing weight regain after such a lot of weight loss and such a lot of effort. And we're thinking about raising awareness in this area. So rather than treating obesity as a behavioural flaw, accepting that obesity is actually a long-term relapsing, remitting condition, and that we need to think about not only coverage for anti-obesity medicines across our healthcare systems, but also how we tackle those that can't gain access. And we need to think about the variation in which the variation of options that people face to manage their weight. People online hearing messages around eat less, move more, advice about holistic medicines versus evidence-based pharmacotherapy. It's a minefield for people to navigate. So you can see that this area more than ever is really finding a lot of intervention gaps that we need to start to fill. So let's have a look at another case study. So this is Sarah. Sarah's got metabolic resistance, and this really highlights the limits of what willpower will produce. So Sarah's 42 years old. She's a corporate executive, BMI 47, although she looks very svelte in the picture. Class 3 obesity, weight 128. The history of treatment failure for Sarah is that she's tried keto diets, intermittent fasting. You know, this is a story we're all familiar with. She's had 5 to 10% weight loss with that, but it's all come back on. This is also in hand with insulin resistance, antidepressant weight gain, PCOS and hormonal imbalance. And she's got a range of common comorbidities with obesity, such as polycystic ovary disease, obstructive sleep apnea with CPAP. She's got depression, dyslipidemia, and NAFLD. Mental health in combination with physical health is very common in obesity management, and I think it needs to be recognized that this is a bi-directional relationship. And that is something that really we need to do a lot better about understanding, actually, not just the link between long-term conditions and mental well-being, but obesity and mental well-being. And we need to really start thinking a lot more about that in combination, and again, not being siloed in our very blinkered approach, I think, to long-term condition management. And she's a Framingham score of 25, or QRIS, whatever scoring system you use, and that would be high cardiovascular risk, although she's not yet had a cardiovascular event. So where are we now? We have moved into using dual agonism. This is the SURMOUNT-1 trial data here on the screen, which shows excellent outcomes. And if Sarah was to go on to tirzepatide, she may be one of the lucky 57% who achieve more than 20% weight loss, which is starting to cross now the bariatric mimetic zone. So effectively, we potentially are now starting to give Sarah metabolic surgery in a syringe, and at 20% weight loss, what does that mean in terms of clinical outcomes for Sarah? We would expect at that level a remission of obstructive sleep apnea, so weaning off of CPAP, hopefully, a normalization of liver enzymes, so we're catching Sarah's NAFLD before it becomes MAFLD. And we are restoring insulin sensitivity in PCOS. So huge benefits, impactful benefits that actually, and also another thing that's not listed there is that may then have that knock-on effect of improving Sarah's mental well-being. So what do we think is going to change then? And before 2029, I think this will be the era where we move into even higher efficacy and holistic metabolic care. So I think we have some really advanced pharmacotherapies coming. I've only named 2 here, but there are hundreds in pipeline at the moment in phase 1 and phase 2 clinical trials. But the ones that kind of we're anticipating, I suppose, in the UK are the triple agonists, for example, retatrutide, and also the orals such as orforglipron, which would be one that would focus mostly on maintenance rather than induction. So we're starting to see now a range of options for different scenarios in obesity management. But that all needs to be supported by some wraparound care, and I think that needs to be multifaceted. We need to embrace digital and diagnostics in a much more broad way than we have ever before, mostly because actually our healthcare systems will be overwhelmed if we try to manage everybody with overweight and obesity at the same level. So we need tiers or not tiers, or we need a way of stratifying where people are at in their obesity journey and managing it in different ways. AI subtyping, I hope to see, and this may look at whether people are a hungry brain or a slow burn phenotype, for example, and we can then instill in people more prescription digital therapeutics for things like cognitive behavioral therapy, before somebody maybe even becomes eligible for pharmacotherapy intervention. And we need to think about systemic integration, so things like food as medicine reimbursement, and thinking about endoscopic options and pediatric approaches. fundamentally, this is a rapidly changing environment with lots and lots of different facets to it, and hopefully that just gives you a flavour. And just to come back to some of these advanced therapeutics that we're going to be seeing in the next few years, retatrutide is triple agonism. And basically liver fat modulation. So we're seeing 24% mean weight loss at 48 weeks with the higher doses, with 100% of patients who are on the 8 and 12 achieving more than 5% weight loss. So this is a step up from that dual agonism. And what are the clinical implications for that? Ideal for patients who have significant obesity, showing markers there of MASLT, and to break plateaus seen in single and dual agonism that we have been observing. Orforglipron, different cohort here, in my opinion. Injection. Pens need cold chain, and really this is a solution to that, so no cold chain required. Mean weight loss is less, but 54% still achieving more than 10% weight loss, and it seems to be a similar sort of safety profile. It's the democratizer. It solves the needle phobia and the logistics, and it's projected to replace injections for maintenance or early stage intervention, reducing costs and expanding actually global reach, which is really important. So we're redefining remission and organ protection, and we're starting to think about that proactive remission. So we're using our cardiorenal shields through some of the drugs that we've got. We're starting to look at enhancing biology. We're thinking about scalable access, and we're thinking about correction. So the gap is no longer capability, it's implementation. The future of care is actually proactive, it's personalized, and it's biologically targeted. Thank you very much.
Brilliant. Thanks, Sada. I suspect we'll come to the questions later on, Vanshi. Yeah.
I think at the end we can have the discussion.
Okay. So can I introduce my next colleague, who's a nurse consultant, Jane Diggle. She's been qualified as a doctor here as well.
Oh, I know. You promoted me, Naresh.
Exactly. I think Hannah did talk about the depressing side of mental health and how it impacts people living with diabetes. So you're going to help us look at what's beyond the physical, the emotional impact of diabetes. So the floor is yours.
Thank you. Thank you so much. It's a pleasure to be invited to present to you here today. I know it's evening time in India. We're just lunchtime here. I am a diabetes specialist nurse. I'm actually based in West Yorkshire in the north of the UK. I've been in my current practice for about 6 years now, but over 20 years working in primary care. And I've been part of the Primary Care Diabetes and Obesity Society for a number of years now, in fact, probably about 16 years. I'm just going to give you a moment. Everyone, I hope, can see my slides. Naresh, just give me a nod to make sure you can. This is my disclosure slide. So one of the things that I've probably been most proud of, actually, over the time that I've been with the Society is my role as editor-in-chief for the journal. So it's the Society's journal, Diabetes and Primary Care. And it was a real honour for myself and for my co-editor, Dr. Pam Brown, to be awarded the Outstanding Educators in Diabetes at the Quality and Care Awards last year for our work on the journal. So do take a look at Diabetes on the Net. We have really moved towards very practical guidelines in the journal, so do take a look. So we really focus, I think, on the physical side of diabetes, but what I'd like to do is move away from that over the next 20 minutes, and I'd like you to think about how living with diabetes affects a person's emotional health and well-being. So these are my learning objectives for the session. So what I'd really like to do is raise awareness of just how common psychological problems are in adults living with diabetes, and look at the impact that that has on their lives, but also on the lives of those around them. I'd like to share some tips on how we as clinicians identify emotional problems in people with diabetes and how we talk to them about it. I'll also be sharing some practical tools and some information that can support these conversations. So I hope you enjoyed the session and I hope you found it useful. So, obviously, a key goal in diabetes management is, of course, to prevent the diabetes-related complications. So both the long-term complications that we're all very familiar with, Hannah's already mentioned some of that, but also some of those short-term complications, some of which will be associated with the treatments that we're using. But you can't separate the physical from the psychological. There's this two-way relationship that exists between them. So worry and fear about developing those devastating complications, amputations, blindness, kidney failure, can sometimes paralyze a person's ability to self-care effectively. And of course, when a person feels anxious and stressed, often blood glucose levels will rise. And of course, that in turn increases the risk of those physical complications. So what we have is this vicious cycle. We know that self-management is absolutely key. Diabetes is a self-managed condition. And what I'm trying to put over in the slide that I'm showing you right now is that in a whole year, a person may spend around 2 hours with their healthcare professional. But in the other 8,758 hours a year, they are managing their diabetes. So what we have to do is give people the support, but also the tools to allow them to do so, to self-manage to the best of their ability. But I think we have to acknowledge the fact that diabetes is complex, it's a demanding condition, and effective management really does depend on the person's ability to care for themselves. But it demands constant attention and awareness, and that can be a real challenge to cope with. There was some research done in Stanford University with people with diabetes, particularly those who are using insulin to manage their condition. And the survey showed that they make probably around 180 more decisions every day about their health than somebody who doesn't have diabetes. So that's equivalent to an extra decision every 5 waking minutes. So that can have a huge additional mental burden. People are having to think about what to eat, how much to eat, when to eat, whether or not to give any medication. If they're giving insulin, when to give it, how much to give. They need to think about their activity levels. And of course, they may need to be monitoring their glucose levels too. So here are some of the things that might cause additional stress for people living with diabetes. And I think it starts from the very beginning. So as soon as somebody is diagnosed, there can be feelings of guilt. That's quite often linked to stigma and discrimination. I'll talk a little bit more about that in a little while. There really is a steep learning curve when somebody's diagnosed with diabetes. So many new things to learn, lots of things to remember. Understandably, people worry about the impact that this diagnosis will have on their current and also their future work prospects, their home life, their relationships. It just affects every part of a person's life. People will have to pay closer attention to their diet and food choices, their activity levels. They may have to take medication, give injections, monitor blood. They will be probably worried if their results are coming back high, if they have high HbA1c, particularly worried about those long-term complications that I mentioned. And there often will be a greater focus on weight and body image, particularly in those who are overweight or obese. People living with diabetes often encounter stigma. Diabetes UK is our leading UK charity for people affected by diabetes, and they've led a campaign for several years now to raise awareness and strike out stigma in diabetes. 80% of people living with diabetes have faced negative attitudes purely because of having diabetes, possibly meant as jokes, but nevertheless hurtful. And I think sometimes the comments that are made are not intended to be harmful or hurtful, but they are, and possibly born out of misunderstanding and myths about diabetes. But the problem is all of that just reinforces the guilt a person feels. It affects their self-esteem, they start to doubt their capability, and certainly it adversely impacts on their ability to self-manage. People with diabetes are twice as likely to have depression and 20% more likely to experience anxiety disorders. And sometimes that is directly related to their diabetes. So a report published back in 2017 by Diabetes UK surveyed over 9,000 people affected by diabetes. And something that came out really loud and clear was that living with diabetes can be exhausting. It's relentless. There never is a day off. And it affects everything, as I've already said, food choices, activity, relationship, work, social life, holidays. But often there is that lack of understanding about the condition. Possibly that might be in a person's workplace, perhaps amongst their friends, and that can end up making somebody feel really quite isolated, misunderstood, and stigmatized. And I think people can often feel very alone and unsupported, even sadly by their healthcare professionals. Diabetes distress is distinct from depression. So this is a condition that arises directly from the demands and constraints of living with and managing diabetes. It reflects the emotional stress and burden of living with that condition. It is often characterized by feelings of frustration. The person can feel overwhelmed and almost defeated by their diabetes management, and it becomes very difficult for them to self-manage. It is common. 1 in 4 people with type 1 diabetes, 1 in 5 with type 2 are believed to have high levels of diabetes distress. The condition can lead to diabetes burnout, which is a point really of emotional exhaustion, where the self-management tasks are just completely overwhelming. And as a result, people tend to disengage from self-care. They may be engaging in unhealthy practices, perhaps uncontrolled eating, risk-taking behaviours really. And it can often be associated with non-attendance at clinic consultations. I think sadly, it can sometimes be perceived as healthcare professionals as a person being difficult, perhaps being non-compliant, not motivated. But actually what's happening is they're really struggling with that relentlessness of managing their long-term condition. In the UK, there was a survey and it showed that 7 out of 10 people reported that they rarely or never were supported by their healthcare teams to have conversations about their emotional well-being, which is worrying. I think even if there is just a perception that we don't care, it's really important that things change. And that's why Diabetes UK have really picked up the campaign for better emotional and psychological support in diabetes care and to make it core part really of routine care. Certainly in the UK, I think there's a long way to go. A lot of recommendations were made, and I've included the reference there on the slide for you from the document called Too Often Missing. Lots of recommendations at kind of system level on how services should be delivered, about the provision of specialist diabetes psychological support. This is something actually that's really quite rare in the UK. Education and training of the workforce is key. But what I want to do right now is really think about what we can do as clinicians to have better conversations in our consultations. I think what we need to do is recognize that many people might be struggling emotionally, and I think we need to ask about it routinely. And then we need to be able to assess a person's mood and emotional health. And I'm going to share with you a couple of tools that can help us to do that more objectively. I think, yes, we definitely need to offer support and advice, and we also need to be aware of any additional support that's available in our areas and how to access that. What I'd really like to do is share this resource with you. This is a really comprehensive guide, which was published back in 2019 in the UK, which was actually based on an Australian publication. As you can see, it covers a variety of psychological conditions relating to diabetes. So from coming to terms with the diagnosis to fear of hypos, reluctance to move on to insulin. We've got anxiety, depression, diabetes distress. So a really comprehensive guide that's divided into chapters. Now, throughout the chapters, they refer to the 7 A's model. And this really just provides a framework for assessing and addressing a particular psychological issue that the person's facing. So there are 7 steps. First step, being aware that the person may be experiencing, for example, diabetes distress, if we use that as one of the particular issues. So we need to then ask about that distress. We need to assess it objectively. And in a minute, I'll show you a validated questionnaire that you could use. We need to consider assigning to another healthcare professional with specialist skills if we feel that we can't deal with it, but we may actually be able to advise and assist. And finally, we need to arrange a timely follow-up. So let's look at that in a little bit more detail. So in terms of awareness, what are we looking out for? These are just some of the signs that we might want to be looking out for. So unstable blood glucose levels, or perhaps suboptimal HbA1c. If a person's not attending for those clinical appointments and their engagement is reduced. Person might actually describe to you poor sleep patterns, waking early, a poor appetite, or perhaps conversely, overeating. There might be tiredness, lethargy, and overall negative feelings about self-worth. Person may have ineffective strategies for dealing with stress, such as emotional eating. Of course, there can be lots of other things in a person's life that can be compounding a problem, financial problems, worry over work. It could be related to relationships. The person might appear passive, but then again, they may appear aggressive during consultations. So those are just some of the things that you might want to look out for. We need to ask the person how they are feeling. And I think that sometimes we don't do that, perhaps routinely. Perhaps we feel that we're intruding on something that is deeply personal. But this is what one person with diabetes said. I would like to be asked, how are you? Not how is your diabetes? How are your sugars? How's your sight, your feet, your kidney function? I'm not a computer screen or test results. And even a nod to that would improve matters so much. We have to not lose sight of the fact that we are all human. And I think these soft skills really do matter. I've just given you a few examples, perhaps of some phrases you might want to use. So I think open questioning is really important. I think acknowledging the difficulty that people experience managing their diabetes. And I think pointing out that that's quite common is good, but just because we normalize it, we shouldn't minimize it. It may be common, but nevertheless, it's still very difficult for somebody to manage. So just giving you some examples there on the left of the screen of some open questions that you could ask. But I also wanted to signpost you to a wonderful book that's been written by a colleague of mine. She updated it and published the Oxford Handbook of Diabetes Nursing last year. I'd highly recommend it. And within the book, Rose Stewart has written a chapter on the psychological issues in people with diabetes. So I've taken something from there, a little tip. She recommends asking the magic question. What's one thing about your diabetes that's really getting to you at the moment? So think about asking people that. I think that would be useful. I would like to take this opportunity to remind you about the language that we use in our appointments and also in our communications, because it plays a really important role and I think has the power to give people confidence and to motivate a person. But equally, if it's not done well, it can leave a person feeling defeated and a failure. So I would really encourage you to take a look at the Language Matters movement. It goes through lots of things, suggesting that, we don't use words that will imply judgment or shame. I think the word control is something that implies that it's something that's easily kept in range, for example, blood glucose levels, and that's not true. I think we need to avoid language like failed to control or failed on therapy. I think treatment needs have changed. We need to be more understanding, I think, of the challenges that people face in their lives. It's complicated, influenced by so many factors, and that constant need for monitoring and decision making. And I think we need to recognise the daily efforts that people are making. So those are the two validated questionnaires that I said I would mention to you. I think both the problem areas in diabetes and also the diabetes distress scale could be helpful in uncovering really some of the underlying issues that the person is facing so that you can focus on those. And I think this is a tool that you might want to invite somebody to complete before the consultation or maybe during the consultation. I'm not a psychologist. I think if you have the skills and confidence to support the person yourself, I think you should, because after all, they've confided in you for a reason. And I do think that one of the advantages for those of us working in primary care is that we can establish a lasting and trusting relationship that builds over time. But I think we also need to recognise the scope of our practice, our competencies and our skills, and also know when to refer on to somebody else with those specialist skills. And there may be a point where you feel that it is appropriate and it's in the person's best interest to do that. So we need to know what's available in our area and how to access those services. To finish, I just wanted to include some examples of resources that we have available in the UK. I'm sure you have very similar where you are. I think a number of leaflets that we can share. We also have an information prescription, which I think is also quite useful because that can help us to frame the conversations in our consultation. And there are just a few more examples of some leaflets that can be downloaded and shared with individuals. And as I said, I'm sure you have something similar. So I'd like to thank you for your attention and just remind you about this striking out stigma in diabetes. You know, I think we do need to change the narrative. People should not feel to blame for having diabetes. And I think we have a responsibility as healthcare professionals to get behind this campaign. You may like to know that on the 28th and 29th of March, the Global Stigma Summit takes place in Jaipur in India. So if you're free, you might want to attend. I don't know how close it is to where you're based, but it's interesting that that's taking place. I think our next speaker, Sam, might hope to go there actually to this summit. So thank you for your attention.
Thank you so much, Jane. That was fabulous. And I think it just shows us, highlights the importance of some of the issues that we don't usually tackle. Sam, I'm going to bring you in because I know you are rushing off to a meeting as well. So this is, I'm sure most people know Sam in India, Prof. Sam Saidu, University of Leicester, fellow GP and also committee member of the Primary Care Diabetes and Obesity Society. He's just going to look at health inequalities and what the data shows us. Sam, I'll let you jump into it, buddy. You're on mute, Sam.
Okay, is that better? Can you hear me all right now? Yeah, great. So my disclosures, so quickly, yes, Naresh mentioned health inequalities, but I kind of weave it into cardiometabolic medicine management in the primary care setting, in the context of diabetes. And we'll do a little bit about the implications of that in primary care on our consultation rates and effects on the patients and their life expectancy and any disparities that you may get as a result of that. Now, we have been talking about diabetes management for a long time, and until the past 10, 15 years, where we started focusing on the cardiovascular outcome trials and recent as obesity, the focus had always been on managing cardiovascular risk factors, glycemic control, blood pressure control, lipid control. And despite the availability of these new therapies over the past 2 decades, we have been struggling to achieve these targets. There hasn't been any significant progress made since the past 2 decades with respect to A1C, except in North America, where they had a lot of luck with blood pressure control. So, when you talk about A1C reduction with all your glycemic agents, blood pressure control, lipid control, it has actually been seemingly very flat. And we don't know why, despite the new agents. So maybe now that we're getting all these potent medications that have multiple indications, such as the GLP-1 receptor agonists, the very potent ones, we might actually be cracking it now. So here's the data that we published recently, looking at the global guideline, target achievement of guideline recommendations. So when you talk about A1C, only 44% of patients across the world are achieving A1C target, and 41% are achieving blood pressure target, and 47% getting LDL targets. Like I said, in North America, they're kind of doing slightly better than us in Europe. And we in Europe are also doing a lot better than the rest of the world. And so the fact that you're getting semaglutide as a generic, soon, actually is a very, very big push for you guys in India, because these drugs that have multiple indications, good weight loss indications, good A1C reduction, anti-inflammatory activity that has impact on MACE, actually is going to push the dial further for you guys there. We're still struggling to get these drugs for a lot of our patients. When you achieve control much earlier on, as you know from UKPDS, you get a huge legacy benefit further downstream. And that is not just for glycemic control, even blood pressure control. You control blood pressure very early on, you get a legacy benefit. We now have data for up to 10 years, lipid control for up to 18 years, and multiple risk factor control for up to 21 years. So there is something to be said about controlling these patients' cardiovascular risk factors very early on in diagnosis and maintaining them to target for as long as possible. One of the things we don't do very well is actually getting everybody in primary care setting to do this risk factor control properly. So here I pick on A1C. So this is a paper we published just a couple of months ago, looking at primary care data in Spain, over 300,000 patients with diabetes. And we looked at patients who had good control of their A1C, below 7%, compare that to control between 7% and 8%, those over 8%. And then we'll compare all of that to those who did not have any recorded value of their A1C at all. So not having somebody's A1C measured at all, does that increase the risk of cardiovascular event? And this is what we found. For those who are poorly controlled between 7 to 8%, the increased risk of cardiovascular disease is 18%. Okay, for A1Cs poorly controlled over 8%, the increased risk of cardiovascular disease is 41%. Now, if you don't have A1C recorded at all, it's almost 300, times elevated. Your risk of getting cardiovascular, disease is almost 300 times. And so those patients that you cannot get to come in and do their testing, okay, they carry all the burden. Okay, so if you cannot do anything, when you get them in your one-off clinics, it might be a good idea to spend a little bit of time on them and try to do the multifactorial control. If you are struggling with adherence, it might be a good idea to consider a potent agent that can address multiple organs at the same time, such as we're talking about in semaglutide in the case of the GLP-1 receptor agonist. Then you can achieve the maximum within the minimum of time that you have with this patient. Because if you don't get their A1Cs measured, this is actually what happens to them. People with diabetes, don't just have diabetes alone, and diabetes on its own decreases your life, your life by about 6 years. If you have diabetes and cardiovascular disease, that decreases by about 12 years. You throw CKD in the mix and it decreases by up to 16 years. And so thinking holistically, not just with diabetes, but diabetes, cardiovascular disease, and chronic kidney disease, if you can get an agent, or indeed if it's lifestyle intervention, whatever you can do that can address all of these, organs at the same time, they are more likely to increase a patient's lifespan. So we have had a few mentions about diabetes and depression. Jane mentioned that, Hannah also mentioned that. So it's another analysis we did a few years ago, looking at, how much life years you lose if you have diabetes or diabetes and cardiovascular disease or diabetes or depression. So for somebody with just diabetes, you're looking at only about, probably 3 years of life lost. But if you have diabetes, cardiovascular disease, and depression, the three of them, okay, you're talking about losing about 9 years of your life. Diabetes and cardiovascular disease is about 7 years of your life, and diabetes and depression is about 4 years. And so the multiple combination of these conditions, diabetes, cardiovascular disease, and mental health, actually reduces the number of years that you're expected to live on Earth. What can we do in primary care? Well, we want to manage patients holistically. Unfortunately, we're struggling because of time pressures. There's a huge demand. So here we looked at the UK primary care system, looking at the number of consultations that people have with their GP face-to-face in a year. If you have just diabetes without any condition, you're talking about 10 times a year. Okay, you consult. If you have about 10,000 patients, in your practice, and you have a prevalence of 10%, that is 1,000 patients with diabetes. And if you have to consult 10 times a year, that's 10,000 consultations for just diabetes alone. But patients with diabetes do not just have diabetes on its own. They have diabetes and other multiple long-term conditions, and indeed other acute conditions. So if you have another one comorbidity in addition to diabetes, okay, that frequency of interaction face-to-face with a GP increases 13 times a year. 2 more comorbidities increases to 15 interactions a year. And more than 3, we're talking about nearly 20 interactions a year. So here we're looking at the consultation rates over the past 2 decades. And in this analysis, what we then looked at is, based on everything that I've said, what has happened over the past 2 decades. And if you look at the cardiometabolic space over the past 2 decades, it actually looks like there has been a decline in the interaction with the GP in primary care setting by almost 50%. Okay, for cardiometabolic conditions. However, if you then look at the same time frame, you look at a consultant, a specialist in the hospital, there is about a third increase, 33% increase in cardiometabolic multimorbidity in those populations. So what does that mean? It just means that we cannot, refer every single patient with cardiometabolic condition to the specialist because the systems will crash. We have to empower primary care to be able to do a lot of things that we do to prevent these patients getting the complications in the first place. How about the impact of, health inequalities on all of this cardiometabolic disease? So I'll start off with age. Those over the age of 80 are 10 times, more likely to have multimorbidity. People living in most deprived areas, have over 2 times the odds of getting multiple long-term conditions compared to those in least deprived areas. So deprivation is a huge driver, and age is another, huge factor in multimorbidity. However, when you compare white people in the UK, with Asians, the odds are comparable. People with diabetes develop multiple long-term conditions 20 times, 20 years much earlier, and at much higher rates than those with just, other conditions or without diabetes at all. And by age of 50, those with diabetes will have, 1/3 of them already have more than 3 conditions compared to the general population who develop this at 70. So diabetes drives all these multiple long-term conditions. And, it just opens the window for you to be able to capture all of the multiple long-term conditions together with the diabetes. And when I talk about multiple lung conditions, I'm talking your cardiovascular disease, your kidney disease, and indeed your obesity. So we are now entering into a space where we have interventions that can address all these multiple long-term conditions much earlier on and prevent these complications. Consultation rates in people with diabetes, I've shown this publication already, but like I said here earlier on, healthcare utilization is usually varied by ethnicity in the UK. White and South Asian groups, have the highest healthcare primary care utilization. They see their GP in primary care much more than Black patients. Black patients in the UK have the highest specialist care, interaction. And one could argue that it is probably because the Black populations in the UK tend to wait late. They don't take their cardiovascular risk factor control seriously. So by the time they have an interaction with the healthcare professional, it is when there is an MI or a stroke or something worse, and then they go and see a specialist, which is probably why you find Black people interacting with a specialist more than the primary care teams. Losing weight drives a lot of the benefits. So here in this, publication, my colleague Kamlesh Kunti, who just knocked on my door while I was speaking, he demonstrated here that losing weight or putting on weight drives the changes in the risk factors, no matter what risk factor you're talking about. What are you talking about? Sleep apnea, hypertension, hyperlipidemia, PCOS, asthma, osteoarthritis, heart failure, atrial fibrillation, all of these complications or risk factors, whether you put on weight or decrease weight, will change the dial one way or the other. So here we're looking at the blue dots representing weight loss. Okay, the dark blue represent 20% weight loss, and the light blue represent 10% weight loss. As you can see, all of those dots are under the line of 0, which indicates there is a reduction in the change in those risk factors. Whereas the yellow and the red dots represent weight gain. So a 20% weight gain or a 10% weight gain is associated with an increased risk of sleep apnea, hypertension, dyslipidemia, polycystic ovary syndrome, and so on and so forth. Options for weight management. Hannah has mentioned this already, but we have dietary options, aerobic physical activity, GLP-1 receptor agonist. We kind of stumbled upon these drugs. They came into the market for us to control diabetes, but suddenly we have realized that actually they will do a lot more than glycemic control. liraglutide, semaglutide, those are all options available. And of course, bariatric surgery. Physical activity, don't forget that, healthy diet, body mass index, keep it in shape. Your sleep quality and duration matters. Stop smoking, control your lipids and blood pressure, and you prevent all these cardiovascular risk factors. Thank you very much, and I'll stop here and take questions. Thank you.
Thanks, Sam. Thanks, Sam. That was very interesting and excellent. Bunchy?
Yes.
So it's interesting topics that we had here. And like I said, obviously the three presenters we had did a fantastic job. And I'd also like to say that it's only a third of our committee, and we have another 20 odd people who are equally excellent as well. So anytime you need us, and we can use your support as well to deliver education.
So yeah, I mean, really great, and a lot of questions are there.
Yeah.
One, Sam, which is coming in India very often, as I told in introduction also, that people are lean and thin, but still they are obese. So not lean and thin, the word which I should not use, the word I should use thin Indian or fat Indians, which are, they look like they are not obese and overweight. Their BMI, as such, Asian cutoff is different in compared to Caucasian, because we have been part of that consensus also that above 23 BMI, we should consider them the challenge. But the problem is they don't accept. And that's for primary care, it becomes extremely difficult for them. So at present, what we are getting the patient is like, I'm doing a consultant practice. I will get a person who is already obese. It means his BMI is above 30, having some comorbid condition as per the Lenzen Commission. I mean, they have disease. It's like obesity with some problem. And they've been either referred or they will come on their own that I want to lose my weight because I am having some problem, maybe fatty liver, maybe heart disease, maybe diabetes. But how at the level of primary care, they will have to identify the people with the BMI of 25, 27. They don't have body composition analysis. Person had gone to them for not for obesity consultation. Consultation is for some other comorbid condition or maybe for journal fever or something like that. Now, how to deal with it? And this is question keep on coming. Then how we identify or increase awareness in society for that. Any one of you have. When Naresh also.
Sam and then Hannah. Sam, you're on mute again, buddy.
Yeah, I'll just say that Hannah kind of alluded to that in her presentation. I think we're entering the era of precision medicine. The BMI cutoffs at the population level make sense, but when you're talking individual, patients, we'll probably need to be more innovative in addressing obesity rather than just focusing on BMI alone. Like central obesity, as you mentioned, in the Asian population, even the UK will recognize it. So our guidance in the NICE will normally subtract 2.5 from our standard BMI cutoffs if we are addressing, the global majority populations in the UK. And I think it's in the recognition of the fact that these populations tend to have obesity at much lower thresholds. The focus on obesity and the prescribing of these good agents actually detracts from the fact that the agents have got other organ protective advantages beyond weight loss. So you can find your thin Asian person who has a BMI of say 24, 25 with a central adiposity, and they probably have a lot of organ damage, a lot of adipose tissue around their liver and the pancreas and everywhere, and that is not good. So precision medicine. So in Leicester, we have been involved in a study where we use MRI imaging to actually quantify how much visceral adipose tissue you have on your important organs, such as the heart, the liver, the pancreas, and use that to determine whether you go on these organ protective medications rather than just using a cutoff BMI. And I think the era of precision medicine is coming where we don't have to just use a blanket threshold of the BMI for everybody. At the population level, it makes sense, but for individual patients, we need to move beyond that.
Yeah. Hannah, do you want to come in on that, Hannah, quickly?
Yeah, some things I think I agree precision medicine is the way forward, and I think there's a little bit of work going on at the moment around imaging with this. So things like full body imaging to show people actually so they can see a little bit more, make it more tangible. I think sometimes it's difficult, isn't it? It's a little bit like diabetes in that way, that although physically they can, if you're a normal weight person, it can be more difficult. So that full body imaging can be a lot more effective to see that ectopic fat, and also marrying that then with things like liver function tests, etc., if there are signs of NAFLD. So I think that's probably the two things that are probably on the horizon, and a lot more. And I think that's why trials are getting done in NAFLD a lot more frequently.
So I think, Bunchi, one of the things we are raising awareness of as well is we have a lot of South Asian population in the UK and a lot of the city center areas as well, and trying to encourage our healthcare professionals to think a little bit more when they see a thin South Asian, and not to think, well, they might not have diabetes, because they were present for high blood pressure. A lot of them seem to have heart attacks sooner than they should. And so we're trying to get them to encourage them to think a little bit more when you see people from South Asian origin about the risk factors and the chances that they have diabetes, even though they don't appear obese.
Naresh, one more problem is in India, it is officially approved, newer anti-obesity medicine, only to be prescribed by endocrinologist or by internal medicine specialist. So not by family medicine specialist official. So what's the situation in UK or other parts of the world? Can it be prescribed by here? It is out of pocket, so patient has to pay from their pocket. It's not like that any insurance company is paying them.
Yeah.
But still, as far as prescription is concerned, officially it can be prescribed as per DCGI Government of India rules, not by any other specialist except internal medicine and by endocrinologist. So what is the situation in UK?
In the UK, it is slightly different but similar, because you can prescribe in primary care medications for weight loss if it's associated with diabetes. For pure obesity alone, I think there are different programs in place in the UK where if you have pure obesity, they go down a different pathway. And so the therapy is, we're getting into the point where we are going to be prescribing, but it's under guidance which is coming centrally for us. That's where the situation is. But again, the big thing for us, like you're in India as well, is the private prescriptions for obesity that is happening constantly. And then it just takes a while for us to understand where they're getting the prescription from and making sure that they're getting it appropriately and things like that.
Vital sign. I have kept one talk also during our Diabetes India too. So how often people in UK, they use hand grip as a strength to know about after losing the weight or previously whether person is doing muscle building exercise or not, or how commonly by all primary care they rely on body composition analysis.
So I'll ask my colleagues that, but as far as I'm aware, hand grip strength is very infrequently used. Probably we should use more of it. Body composition is not done in primary care. In a lot of it is mainly either specialist care or private. So Jane, Hannah, what's your experience with the hand grips or anything like that? Have you seen anybody use that? No.
Never seen anybody use that, actually. I think it would be useful, wouldn't it? And I think we're not doing enough around the sort of holistic monitoring of somebody.
It's the wraparound care, really, isn't it, when we're initiating therapies like this? And I think people think, oh, weight loss, that's fantastic, but don't bear in mind that it's not just fat that you lose muscle, and you have to therefore give counselling around the type of activities and food that people need to eat to maintain their muscle.
So there is something then, Bunchi, for us to learn from you guys about how you're implementing hand grip strength and things like that as part of the management algorithm for you. So it's something that we need to look at.
So because we are muscle mass in Indians is comparatively less, we are more worried of sarcopenia. So what we do as a part of obesity assessment, even someone BMI maybe 25 or 28, we do BCA more often. We try to do more muscle strength to know about from hand grip strength. We also measure anthropometric data, definitely waist circumference
Yeah.
or abdominal girth. We try to measure for each
Height
and
to
every
waist
person.
ratio.
Try to understand that. Yes, that's very important. Visceral fat. And especially center like my center, we are running with obesity clinic. We have a exercise physiologist who explain them that what are the different exercise one should do. We not just depend only on aerobic or just 30 minutes walk is insufficient. We explain them about muscle strengthening and some abdominal muscles exercise also.
Yeah.
Abs. Yoga is very common, which we ask them for pranayam and lung exercise and yoga for stretching and particularly for abdomen stretching. So these are some of the things which we do very often. The other challenge comes is for continuation of therapy.
Yeah.
So at present, these medications are available to our countries only in 6 or 8 months, 9 months maximum time. Before that, we were having oral semaglutide, which is not an officially anti-obesity medicine, or liraglutide in a higher dose, which was approved in India. But these other medication came little later. Now we are using it's one of the fastest growing molecule at present, must be having ISL. But still, to continue it, because the second question which is asked by the patient that how long I have to continue. We know that answer is lifelong till you want to keep yourself under good control or you have. So you should be continued long enough, but most of the patients have that one complaint related to how long and what will happen.
It's a cost
And the
in it
third
as well,
Banshi. Because in India they have to pay from their pocket. And good news is that this semaglutide will be off patent, so that I just introduce you some before webinar started. That will be in month of March. But then again, the cost will be still it will be high for the Indian perspective.
But what about
currently we are paying almost like £100 per month for this and 150 for tirzepatide, 100 for semaglutide minimum. That's
not bad. But what about the other things that Jane talked about then, Banshi? Do a lot of practitioners look at the psychological side of things, or how much of the behavioral side of things is being done in India?
Actually speaking, we do ask the persons to change their behavior, but we don't have very often behavior psychologist with us or social psychologist with us. So that's a really challenge. And still patient dependent mainly on doctor, but we have nutritionist or you can say come educator, and definitely exercise physiologist is physiotherapist. He is increasing. That paramedical person is now in most of obesity clinic now we are having, but not psychologist. Unless person is having some psychiatric issue, then we send to a clinical psychologist or a psychiatrist.
Okay. But what about, do you use a lot of apps or anything at all?
Yes, there are applications and multiple startups are there. And they educate, online education programs are there.
Okay.
They teach it also. Some of them are actually quack too, so it's not necessary all of them are. So, and they keep on, some of the nutritionists are also running obesity clinic without the support. Doctor too, independently. And they're calling themselves as a weight management center or obesity clinic. And just depending on the diet plan, which they continue to send the patient on every day on WhatsApp. They ask them to take the injectable.
All right. So we have, Jane showed you the thing about Diabetes My Way, which is a thing that is used as a educational platform in the UK, supported by the NHS and everything. I mean, that I think is available. I think they're trying to get it across to India and everything like that.
What's the name of that?
Diabetes My Way, or My Way Diabetes. Okay, I'll send you the link for that. And I know the person, so we can link up if you want. And I think it may be something. Yeah.
There's one more, we were just talking about the stigma. There is stigma for type 1 diabetes. And we have a meeting, and just before some time, Jan had written on that. And I'm part of it as IDF Southeast Asia.
Yeah, I saw that as well. Yeah.
Endorsing it, and we are part of it.
Yeah.
So in India, the obesity is also a stigma all over the world. You know that. But one more stigma is that those who lose the weight, people keep on asking the family and relatives that why you lost weight, what What is that? Do you have any problem?
Yeah,
Why
yeah.
don't you investigate yourself? And indirectly, directly, by any means, they got to know that you are on some medication, then they will make sure that you will off the medication. Don't
Yeah, yeah.
take this.
So that's another reverse stigma.
Other side of, I think weight losing is also a stigma. It's not just, the weight. What do you say? What is your knowledge?
No, absolutely. I mean, I know.
Indians and Indian friends and Indian
Yeah.
relatives. This is very
If I go to India, my mom first thing she says, "Oh, you've lost weight. You're not eating. Your wife's not feeding you." And I'm thinking, no, I feel
exactly.
so. I can see that point as well.
Because that in India, the person who is eating well and taking 3 times, 4 times a day food and everything, it means he is healthy. They consider
Prosperous.
him as a healthy rather than someone who is not eating, losing weight. That's creating more problems. That's the other side of the story.
Absolutely. That's brilliant, Bunchy. So it's fantastic
Thank you.
doing the webinar with you guys. So thank you,
So
Jane
I
and
just take
Hannah
one
and Bunchy.
photo and
Yeah.
then we stop it. So we can put it somewhere.
Or smile.
Thank you.
Thank you, Bunchy. So I'll see you in a couple of weeks.
Yes.
And
Hannah and Jaren is also coming there?
no, they'll be there next time, surely.
Okay.
We'll all be there in force,
So
Bunchy.
who are there with you? You
So
asked them?
I'm coming, and my henchmen, they're just tagging along, Nikki and Paul Newman, but they're going to see my mother, really, not me.
Okay, good. Bye.
Okay.
Bye.
So we'll see you again. Thank you so much.
Thank you.
Take care.
Thank you for.
Thanks, Anna. Thanks, Jane.